Hello. Sorry for the inconvenience. I hope I'm audible. So I'll just start off again what I'm going to discuss today. It's about cirrhosis of liver. So in cirrhosis, we'll be discussing the definition, a little bit about the history, about the pathophysiology, clinical classification, as well as morphological classification, and individually about the each etiology. So now we come to the cirrhosis means is derived from the Greek word called as kyros, which means orange or tawny color, and ossis means condition. So WHO definition says that since we know it's a chronic liver disease, it's a diffuse process which is characterized by replacement of liver tissue by fibrosis, scar tissue, regenerative nodules, leading to progressive loss of liver function. So coming to the pathophysiology, the primary event is injury to the hepatocellular elements. This initiates inflammatory response with cytokine release, that is toxic substances. So destruction of hepatocytes is the bile duct cells and vascular proliferation of the endothelial cells. There is repair through cellular proliferation, regeneration, and formation of fibrous scar. So coming to the classification of cirrhosis, we have morphological classification and etiological classification. So morphologically we have micronodular and macronodular. So micronodular is always says that is less than 3 millimeters formation of nodules. Macronodules are more than 3 millimeters, and you can have in case of hypoxia and certain conditions like vascular compromise, you can have mixed nodules, that is micro as well as macronodules. So etiological is alcoholic cirrhosis, which is the most commonest of 60 to 70%. Post-necrotic cirrhosis is around 10%. Biliary cirrhosis is 5 to 10%. And pigment cirrhosis, which involves the hemochromatosis. Then you have other diseases like Wilson's disease, alpha-1 antitrypsin deficiency. Then you have cardiac cirrhosis, Indian childhood cirrhosis, cirrhosis in autoimmune hepatitis, and other conditions where you have non-alcoholic causes for steatohepatitis, and some metabolic and infectious and infiltrated diseases. Morphological classification, in that you have micronodular. So you can see the gross picture where you have small nodules which is regularly placed, which is around 3 millimeters in diameter. So here it involves diffuse involvement of all the hepatic globules forming nodules by separated by thick fibrous septa, which may be portal central, or both. So then you have macronodules. So you can see this gross picture shows you macronodules, which is more than 3 millimeters, and the pattern of involvement is more like usually it will be irregular. So more sparing some of the portal tracts and central veins. It corresponds to post-necrotic, or is called as post-hepatitis cirrhosis. So coming to the alcoholic liver disease and cirrhosis, which is the most commonest one. So we have alcoholic liver disease is a maladaptive state in which hepatocytes respond in an increasingly pathological manner to alcohol. You have a spectrum for this, that is alcoholic steatosis, alcoholic hepatitis, and alcoholic cirrhosis. This is a chart showing here steatosis, which involves a fatty change. So the normal liver can undergo steatosis. Then hepatitis, where inflammation is there and formation of inclusion bodies and fatty change. And then you have formation of nodules, that is hyperplastic nodules. So what are the risk factors for this disease? So you have to know that alcohol is the most commonest one. So the drink patterns include chronic and excessive consumption of alcohol leads to fatty liver. That is more than 90% of the chronic alcoholics. So progression to alcoholic hepatitis is seen 10 to 20% of the cases, and eventually to alcoholic cirrhosis in another 10 years. So daily imbibing of 60 to 80 grams of ethanol in any type of alcoholic beverage for at least 10 years results in alcoholic cirrhosis. So liver injury is related to the quantity of ethanol contained in the alcoholic beverage consumed and its duration. So coming to the gender aspects, women have increased susceptibility to develop alcoholic liver disease with much lesser alcoholic intake of 20 to 40 grams per day. This progression is linked to effects of estrogen. So next is the malnutrition, where you have absolute or relative malnutrition of proteins and vitamins. And then additional factors for malnutrition in alcoholics is chronic gastritis and pancreatitis. So some of the infection, most commonest infections among the hepatotropic viruses is hepatitis C virus infection. So what's the pathogenesis? Exact pathogenesis is not known. They always say this alcoholic liver injury along with the in chronic alcoholics with the above risk factors leads to the pathogenesis. So coming to these factors, how alcohol causes destruction of the liver. So you have chronic alcohol ingestion, you have direct hepatotoxicity, then inflammatory markers which causes destruction of the hepatocytes, then hepatotoxic, that is metabolites like acetaldehyde which is hepatotoxic. Then you have oxidative stress, that is the free radicals, and the production of the autoantibodies towards the hepatocytes. So these are the 5 mechanisms which causes the destruction of the liver. So coming to direct hepatotoxic by ethanol. Ethanol ingestion for a period of 8 to 10 days regularly may cause direct hepatotoxic effect on the liver and produce fatty change. Ethanol is directly toxic to microtubules, mitochondria, and the membrane of the hepatocytes. So you have the metabolites, ethanol metabolites. The production of protein aldehyde adducts, which are toxic, cause cytoskeletal as well as membrane damage and bring about hepatocellular necrosis. So formation of this malondialdehyde, acetaldehyde adducts produce autoantibodies and initiates autoimmune response. So immunological mechanism is cell-mediated immunity is impaired in alcoholic liver disease. So ethanol causes direct injury to the hepatocytes. So coming to inflammation, ethanol damages the intestinal cells. So these intestinal cells elaborate the endotoxins, which release the pro-inflammatory cytokines, that is tumor necrosis factor alpha, interleukin 1, 6, and transforming growth factor beta. So these cytokines and endotoxins produce apoptosis and necrosis of hepatocytes, and this initiates an inflammatory reaction. So coming to the fibrogenesis, which is an end stage with this formation of fibrotic nodules. So this is facilitated by damaged hepatocytes. There is by activated Kupffer cells, direct stimulation by acetaldehyde, and the deposition of collagen and increased transformation of fat-storing ito cells into myofibroblasts and fibrocytes. So coming to the increased redox ratio, increase in the NADH-NAD redox ratio in the hepatocytes results in the increased redox ratio of lactate pyruvate, leading to the deposition of the lactic acidosis. The deposition of pyruvate leading to lactic acidosis. So this altered redox potential leads to fatty liver, collagen formation, impaired gluconeogenesis, and altered serum metabolism, which occurs in the zone 3. So retention of liver water and proteins results in swelling of the hepatocytes, resulting in hepatomegaly. So initially there will be hepatomegaly, and then there's necrosis, that is formation of shrinkage of the liver, formation of nodules. So hypoxia. So chronic ingestion of alcohol results in hypoxic state, which causes hepatocellular necrosis in central lobular zone. So increased liver fat is in alcoholism, chronic alcoholism, there is increase in the amount of fat due to exogenous sources, excess mobilization from adipose tissue, or increased lipid synthesis by liver. So this may account for lipid accumulation in the hepatocytes. So this picture shows you here completely enlarged liver. This is yellowish, greasy and firm with smooth glistening capsule. So it is initially they will be asymptomatic and only hepatomegaly is the presentation. So here microscopically we have microvesicular steatosis and macrovesicular. You can see the small vesicles, that is hepatocytes with intracellular deposition of triglycerides. So this picture shows you about this small fat droplets. Here you have macrovesicles, means there is increase in the deposition of triglycerides. So you have peripherally large cells with peripherally pushed nucleus and some inflammation. So then you have these fatty cysts where you have coalesce of 2 or 3 hepatocytes together forming the fatty cysts. And then lipogranulomas, you can see here the giant cells. This due to this granuloma formation due to lipid droplets. So these are all nothing but the fibrous septa and lots of inflammatory cells. So these are called as lipogranulomas. Next is your alcoholic hepatitis among the spectrum. You have hepatocellular necrosis. So in this picture shows you the central vein surrounding which you have the necrosis and inflammatory cells as well as necrotic debris. These are normal hepatocytes. So here you have single small clusters of hepatocytes in the central lobular zone, that is zone 3, undergoing ballooning degeneration and necrosis. So this is a ballooning degeneration where you have large hepatocytes which completely swollen it is and centrally placed nucleus. Then you have maillary bodies or alcoholic hyalin. These are nothing but the eosinophilic intracytoplasmic. These are the intracytoplasmic eosinophilic inclusions in the perinuclear location within the ballooned hepatocytes. And these aggregates are nothing but the cytoskeletal intermediate filaments. So it is visualized with connective tissue stains like masoncytochrome stain, chromophore blue, or immunoperoxidase methods. So these are the fatty cysts, and these are the eosinophilic mammillary hyaline bodies. So next you have here, where and all you can see, other than the alcoholic liver cirrhosis, where you can see the mammillary hyaline. So these are found in primary biliary cirrhosis, Indian childhood cirrhosis. Then you have cholestatic syndromes, Wilson's disease, intestinal bypass surgery, focal nodular hyperplasias, and HCCs, that is hepatocellular carcinomas. So this is a mammillary body here, and these are the neutrophils, and this is represents the alcoholic hepatitis. So the next stage is your alcoholic cirrhosis. These are completely fibrotic nodules, irregular surface. Its micronodules are present, that is less than 3 millimeters, and sometimes you can have macronodules too. This shows you macronodules which is more than 3 millimeters. So microscopically, this is you have normal hepatocytes as well as ballooning degeneration is there. There is a fibrous septa where you have chronic inflammatory cells. And this picture shows you this special stain which is used called as Mason trichome stain, where only the collagen is being stained. So these are the multiple nodules which is irregular, and you have this fibrous septa, thick fibrous septa with the inflammatory cells. Coming to the general clinical features, you have jaundice, fatigue, weakness, loss of appetite, itching, and easy bruising. So these are the representation of what are the other complications, or what are the other signs and symptoms you see in an alcoholic cirrhosis patient. So you have spider angiomas, hobnailing of fibrotic liver it's called as. You have palmar erythemas, then jaundice, yellowish skin, muscle wasting is there, sparse body hair, and finally there will be encephalopathy or confusion. So you have spider angiomata or spider navy. You have this picture shows you completely vascular region consisting of central arteriole surrounded by many small vessels, and it is due to the increase in the estradiol. So this is a palmar erythema where you have exaggeration of normal spectral mottling of palm due to altered sex hormone metabolism. So gynecomastia, you have your benign proliferation of the glandular tissue of male breast presenting with rubbery or firm mass, and this is due to increase in the estradiol and can occur in up to about 66% of the patients. So next is hypogonadism, which is manifested as impotence, infertility, loss of sexual drive, testicular atrophy due to primary gonadal injury, or suppression of hypothalamic or pituitary function. Liver size initially to be enlarged, and later when there's fibrotic nodules will be shrunken. Then splenomegaly, which is due to congestion of red pulp as a result of portal hypertension. This is called as caput medusae, where you have ascites in portal hypertension, where the blood from the portal venous system may be shunted through the periumbilical veins into the umbilical vein and ultimately to the abdominal wall veins. So manifesting as caput medusae. So next is your fetal hepatitis, where you have the patient develops musty odor to the breath, musty odor in breath due to increased dimethyl sulfide. Then jaundice, where you have yellowish discoloration of the skin and the eye and mucous membranes due to increase in the bilirubin for at least 2 to 3 milligrams per deciliter. Urine may also appear dark. Then you have asterisk. Asterisk is where you have bilateral asynchronous flapping of the outstretched dorsiflex hands seen in patients with hepatic encephalopathy. Others could be weakness, fatigue, anorexia, and weight loss. So this shows you the asterisk, that is flapping tremors. Flapping is Dupuytren's contracture, where you have this fibrotic nodal formation that is in the metacarpophalangeal joints. And this is fibrous cord where you have the proximal interphalangeal joints. So laboratory investigations involve elevated transaminases where you have an increase in SGOT, which is more than that of SGPT, the rise in the serum gamma glutamyl transferase, elevation of serum alkaline phosphatase, hyperbilirubinemia, hyperproteinemia will be there with the reversal of the albumin globulin ratio, prolonged prothrombin time and partial thromboplastin time, anemia, neutrophilic leukocytosis in case of that is alcoholic hepatitis, and in case of secondary infections. So coming to the complications of cirrhosis, you have portal hypertension is the main thing, where there is elevation of portal pressure greater than 12 millimeters of mercury, while normal pressure is usually 5 to 10. So here there will be arterial shunting or mechanical obstruction, hypersplenism. So this is seen in form of moderate anemia, neutropenia, and thrombocytopenia, marked ascites. Then definitely the patient will go for Then hemorrhoids will be the esophageal varices. The last stage will be the liver failure. So what are the symptoms here is gastrointestinal bleeding from esophageal or gastric varices, ascites and hepatic encephalopathy, which I explained to you in the previous slide. Then variceal hemorrhages, where you have 30% of the patients with varices bleeding from them. Often massive bleeding will be there and 50% mortality. Ascites is presence of the fluid in the peritoneal cavity. Therapy is usually diuretics and paracentesis. Encephalopathy, toxic substances like ammonia bypass the liver via collaterals and gain access to the brain. So the patient comes up with symptoms of lethargy, mild confusion, anorexia, reversal of spleen pattern and disorientation and coma. So next is hepatorenal syndrome, where there is development of acute renal failure in patients with advanced liver disease, dysplastic vasodilatation, fall in the symptom, that is systemic vascular resistance, vasoconstriction of renal circulation and reduced renal perfusion. So this leads to oliguria, rising of serum creatinine and low serum sodium. So other things is congenital portal atresia, portal vein thrombosis, then phlebitis of portal vein, trauma of thrombosed, portocaval shunt, parasitic diseases, Pacchiari syndrome, constrictive pericarditis and tricuspid valve incompetence. So coming to the next etiological factor is post-necrotic cirrhosis, which is also termed as post-hepatic cirrhosis. So here there is formation of macronodular cirrhosis, which is characterized by large and irregular nodules, occurring most commonly after the previous viral hepatitis infection. Could be hepatitis C or B infection. So etiology is hepatitis. Here you have 20% of the cases of HBV infections of chronic hepatitis, and about 20 to 30% of the cases of HCV chronic hepatitis develop the cirrhosis in over 20 to 30 years. So drugs and chemical hepatotoxins is toxicity is due to chemicals and drugs such as phosphorus, carbon tetrachloride, mushroom poisoning, acetaminophen and alpha-methyl dopa. These are the commonest drugs. So other certain infections could be brucellosis, parasitic infections like clonorchiasis, metabolic diseases like Wilson's disease or hepatolenticular degeneration, advanced alcoholic liver disease, and some things could be idiopathic. So here you can see the morphology, where you have typical large nodules, irregularly placed, more than 3 millimeters in diameter. Externally, the liver could be small, distorted and irregularly scarred. So microscopically, you can see the nodular pattern. Various nodules is of varying sizes, separated by thick fibrous septa. So this is a regenerative nodule and this is a cirrhotic nodule. So you can have necrosis as well as inflammation and bile duct proliferation. So these are the regenerative nodules where there is normal hepatocyte formation, hepatocyte cell formation. So clinical features is it is seen as frequent in women as men in the younger age group. The parasites may remain, the patients may remain asymptomatic or may present with prominent signs and symptoms of chronic hepatitis. So splenomegaly is the most prominent one. Then hematologic and liver function tests are similar to those of alcoholic cirrhosis. Post-necrotic cirrhosis related to B and C infections are associated with usually hepatocellular carcinoma. So coming to the next is biliary cirrhosis. Biliary cirrhosis is defined as a chronic disorder which is characterized by clinical, biochemical and morphological features of long continued cholestasis of intrahepatic and extrahepatic origin. So they are classified as primary biliary cirrhosis, secondary biliary cirrhosis and primary sclerosing cholangitis. So primary biliary cirrhosis, here you have the destructive process of unknown etiology which affects the intrahepatic bile ducts. Secondary results from prolonged mechanical obstruction of the extrahepatic biliary passages. Then primary sclerosing cholangitis and autoimmune cholangiopathy causes biliary cirrhosis due to the production of the autoantibodies. So next is coming to the individual, what are the clinical features and what are the signs and symptoms. So we define primary biliary cirrhosis as chronic progressive autoimmune disease which is characterized by non-suppurative inflammatory destruction of intrahepatic bile ducts. It is associated with other autoimmune diseases like scleroderma, thyroiditis, Sjogren's syndrome, and rheumatoid arthritis. The condition is predominant in middle-aged women. Male is to female ratio is about 1:9. Then familial incidences, there is elevated cholesterol level with appearance of xanthomas and xanthelasmas. These are small fatty nodules which is present over the eyelid. Then hepatomegaly and chronic liver disease are the late features of the disease. Now we detect here circulating anti-mitochondrial antibodies of IgG class, which is in 90% of the cases, elevated levels of immunoglobulins, particularly of IgM, and increased level of circulating immune complexes are seen. So here you can see grossly, initially you can see the weight is normal or slightly increased. Here it is finely granular uniform micronodules, which is with greenish surface. So microscopically you can see here, this is the duct here, this is the portal triad where you have inflammatory cells of neutrophils and plasmacytes. There's proliferation of the duct here or destruction of the duct here. And this is the hepatocytes which is seeing some ballooning degeneration is seen. So we describe it as inflammation of the portal tract with lymphocytes, plasma cells and macrophages and non-caseating granulomas. So progressive destruction of the bile ducts will be there. So portal tract scarring, bridging fibrosis is the later stage along with cholestasis. So secondary biliary cirrhosis, what are the features we see here? This results from prolonged obstruction of extrahepatic biliary passages. Causes include here extrahepatic cholelithiasis, biliary atresia, postoperative strictures with superimposed ascending cholangitis. Clinical features is jaundice, pruritus, malaise, dark urine and light stools. Lab findings is here conjugated hyperbilirubinemia, serum alkaline phosphatase is increased, GGT is increased to about 90 to 95% of the cases. Bile acids and cholesterol is increased. So morphologically we see here, grossly you can see small shrunken, hard, greenish fine nodularity of the liver surface. Microscopically there is loss of architecture, coarse fibrous septa subdivide the liver in jigsaw pattern. Extensive proliferation of the bile ducts. Cholestasis is seen where there is inspissated bile in small and large bile ducts. Then the formation of bile lakes. Extensive feathery degeneration of the hepatocytes is there, and sometimes you can see the regenerative nodules. So here there is the mechanism, here is obstruction, ascending infection is there, where there is infiltration of the neutrophils of the bile ducts, the severe pylophlebitis, and then you have cholangitic abscess formation. So cirrhosis due to primary sclerosing cholangitis is primary or idiopathic sclerosing cholangitis is a chronic cholestatic syndrome of unknown etiology. It is characterized by progressive inflammatory sclerosing and obliterative process affecting the entire biliary passages, both extrahepatic as well as the intrahepatic ducts. Etiology may be due to viral or bacterial infections, immunologic injury, toxins, and genetic predisposition. Here microscopically you can see here, completely here fibrosing cholangitis of bile duct with lymphocytic infiltrate, progressive atrophy of the bile duct epithelium and obliteration of the lumen. So here you have completely due to the fibrosis, you can have the onion skin appearance. Next is hemochromatosis. Hemochromatosis is a condition where you have excess accumulation of the body iron deposited in parenchymal organs like most commonly is the liver and the pancreas. Here you have hereditary causes as well as secondary causes. Hereditary causes is due to the mutation of this HFE gene and this which causes homozygous recessive disorder due to excessive absorption of iron. Secondary causes could be due to parental iron load, that is transfusions, long-term hemodialysis, aplastic anemia, sickle cell disease, and then myelodysplastic syndromes, leukemias, iron dextran injections. Then you have this hemolytic anemia with ineffective erythropoiesis like you see in case of beta thalassemias, sideroblastic anemias, pyruvate kinase deficiency, and this increased oral intake of iron like in case of Bantu cirrhosis, and congenital air transfer anemias, chronic alcoholic liver diseases, the neonatal hemochromatosis. Now, what is the exact pathogenesis here? They say the hypothesis is mutations is the HFE, HJV and transferrin R2 gene leads to deficiency or absence of hepcidin, which causes increased absorption of iron and therefore there is elevation of body iron stores of more than 20 grams. So mechanisms of tissue damage could be due to free radical formation by lipid peroxidation, then active stellate cells for collagen synthesis, interaction of the reactive oxygen species with iron in DNA leading to hepatocellular carcinoma. So the organs involved here is deposition of hemosiderin is there seen in liver and pancreas, then myocardium, pituitary gland, adrenals, thyroid glands, joints and skin. So clinical features is they present as cirrhosis and then all the features of cirrhosis and pancreatic fibrosis. So morphologically you can see here chocolate brown color of the liver. That is gradually because it is due to deposition of this formation of nodules and macronodule cirrhosis is there. So it's because the blackish discoloration is due to deposition of the hemosiderin. So microscopically you see here initially seen a finely granular golden yellow pigment in the cytoplasm of periportal hepatocytes and later seen throughout the lobules. Then fibrosis develops slowly in the periportal region, later forms the portal bridging and fibrosis. So these pictures show you the bands of fibrosis here, completely the bands of fibrosis. These are all nodules which is there. And these are nothing but the previously explained here, granular golden yellow pigments, the granular golden yellow pigments here in the cytoplasm of the hepatocytes. So this is a special stain here which shows iron deposition in case of pearl stain and this is iron pigments in case of the liver here. So this is special stain, the Prussian blue stain, where you see the blue granules of hemosiderin in the hepatocytes and the Kupffer cells. So coming to the clinical features here, it occurs more than 40 years of age, that is most predominantly in case of males. Then hepatomegaly and pain abdomen. Triad of micronodular cirrhosis is the most commonest one. They combine with diabetes mellitus is seen in 75 to 80% of the cases. Skin pigmentation is seen in case of 75 to 80% of the cases and slate gray color. So there will be cardiac dysfunction as well as atypical arthritis. What is the cause of death in case of hemochromatosis? It's due to cirrhosis, cardiac disease or hepatocellular carcinoma. Diagnosis here, hepatic iron concentration in unfixed tissue is more than 10,000 micrograms per gram dry weight of the liver. Development of cirrhosis will occur when there is more than 22,000 microgram deposition. Clinical symptoms appear after 20 grams of stored iron have been accumulated. Here, the other thing is you can screening of the family members is done and then phlebotomy. Coming to the next disease, which is cause for cirrhosis is Wilson's disease. It's an autosomal recessive disorder of copper metabolism. There is a mutation of the transporter protein that is AT7B gene. So impaired copper excretion into the bile and failure to incorporate copper into the ceruloplasmin, and this inhibits ceruloplasmin secretion into the blood. So accumulation of the toxic levels of copper in the organs leads to toxic liver injury due to reactive oxygen species. The organs which are affected are liver, central nervous system, eye, kidneys, endocrine organs, heart and musculoskeletal system. So coming to the morphology, liver we see fatty change, acute and chronic hepatitis, or cirrhotic nodules could be formed along with massive necrosis. In the brain, it affects the basal ganglia. There will be atrophy of the putamen, then hepatolenticular degeneration. In the eye, there is formation of Kayser-Fleischer rings, that is the green to brown deposits of the copper, in the Descemet's membrane or the limbus of the cornea. The special stains are rhodamine, arubinic acid, and orsine stain for copper associated with protein. Hepatic content, usually it will be more than 250 micrograms per dry weight of liver. So this picture shows you here, there is Kayser-Fleischer rings in the cornea. You see in the limbus, you can see all this is a greenish hue here. So liver cirrhosis is completely formation of nodules and some amount of necrosis here, yellowish deposits. One of the clinical features is it occurs in the age group of 6 to 40 years of age. They present with acute or chronic liver disease. Neuropsychiatric symptoms of mild behavioral changes, frank psychosis and Parkinson's disease are the most commonest one. So biochemical findings will be here decrease serum ceruloplasmin, increase in the copper content in the liver, increase in the urinary excretion of copper, and serum copper levels will not be of much use. It is not of much useful test. So morphologically, you see here acute hepatitis is completely all the infiltration of the hepatocytes by the inflammatory cells, and there is nodule formation here, that is regenerating nodules as well as fibrosis here, and this is inflammation. So then you can have fatty change, you can have microvascular or macrovascular fatty change, and then you have deposition of the copper in the hepatocytes. The next coming to the next disease is alpha-1 antitrypsin deficiency. It's an autosomal codominant condition Homozygous state produces liver disease as well as pulmonary disease. Then alpha-1 antitrypsin is a glycoprotein which is synthesized in the rough endoplasmic reticulum of hepatocytes and is the most potent protease inhibitor. So we have two types of protease inhibitors, that is protease inhibitor MM is a normal phenotype and the protease inhibitor ZZ is the most abnormal phenotype. So abnormally low serum levels of alpha-1 antitrypsin will be present in these patients. So the function of the alpha-1 antitrypsin is inhibition of proteases, particularly the neutrophil elastase, cathepsin G and proteinase 3, which are responsible for the destruction of the liver tissue. So in addition, cutaneous panniculitis, then arterial aneurysms, bronchiectasis and vaginous granulomatosis can occur in this disease. What are the clinical courses? They are present with cholestasis, hepatitis, cirrhosis and pulmonary disease, that is especially the emphysema. So microscopically you can see it as round to oval cytoplasmic eosinophilic globular inclusions in the periperitoneal hepatocytes. So the EM changes with the electron microscopic changes will be dilated rough endoplasmic reticulum and these inclusions are always PAS positive. So this picture photomicrograph shows here completely micronodular or macronodular cirrhosis. And then you have these inclusions. The confirmatory is the presence of the PAS positive granules in the cytoplasm of the hepatocytes. These are the hepatic inclusions. So then you have this PAS positive cytoplasm. This is a previous picture also depicting the same thing. That is a PAS positive cytoplasmic inclusions. This is an electron microscopy showing dilated that is endoplasmic reticulum. So coming to the Indian childhood cirrhosis, it's an unusual form of cirrhosis between 6 months to 3 years in rural and middle class and Hindus in India, or sometimes affects Southeast Asians and in the Middle East. So combination of some common toxic effects and inherited abnormality in copper metabolism has been suggested. Death is due to hepatic failure within 1 year of diagnosis. So what are the 5 histological patterns which is present in Indian childhood cirrhosis? We have liver cell injury, that is where you have the ballooning degeneration to significant damage to hepatocytes. Then you have prominent miliary bodies without any steatosis, neutrophilic as well as lymphocytic infiltrate. Then you have creeping pericellular fibrosis, it will be micronodular as well as macronodular cirrhosis, and significant deposition of the copper and copper associated protein in the hepatocytes. So these are the different types of etiological factors along with the clinical manifestation I've described today. So today we have, so next class I'll be talking about jaundice. So today we discussed about cirrhosis. What is the definition of cirrhosis? What is the pathophysiology of cirrhosis? The morphological as well as you have the etiological factors and individual cirrhosis along with the etiological factors, the pathogenesis as well as morphological features including the gross as well as the microscopy and what are the investigations being done. So next class I'll be discussing about jaundice as well as the hepatic failure. Thank you for patient hearing. If any doubts you have, you can send it to my mail. Thank you.